So for today's lecture in blood banking, we'll be talking about component preparation. By component here, we are referring to the blood units prepared in blood banks, which are then transfused to patients depending on their specific needs. Now, as what you might already know, these blood components or blood units include your whole blood units, packed red blood cells, platelet concentrates, granulocyte concentrates, fresh frozen plasma, and other plasma derivatives. Now, in order for us to make sure that these blood components will be appropriately administered and given to the right patients, we must be knowledgeable of that component's indications and contraindications. And of course, we must be aware of the process of its preparation and storage, because how we prepare and how we store these blood components will have a great effect on the viability of the cells and of other substances that they contain. Once the manufacture of these blood units is achieved, they can be then used for transfusion therapy. And transfusion has been part of treatment for some patients, especially those who are deficient with specific blood products. For example, we have our anemic patients who have very low circulating RBCs. So for them, we could prepare and transfuse packed red blood cell units to attempt to increase their total RBC count. Now, the first recorded transfusion is way back in 1492 when Pope Innocent VII received blood from 3 young men. Unfortunately, all 4 of them died. This unsatisfactory outcome of the first transfusion could be because of certain problems in the manner or in the process of blood collection and at the same time its preparation up until its transfusion to the recipient. One of the primary obstacles back then is the fact that once blood is exposed to an in vitro environment, it becomes clotted or it coagulates. So how can we actually transfuse blood to our recipient if upon collection, it will gradually begin to coagulate? So this resulted to the attempt to discover non-toxic anticoagulants to prevent clotting. And those attempts were successful because they discovered several anticoagulants that inhibits the clotting of blood units before they could actually be transfused to their recipient. The discovery of these anticoagulants allowed the occurrence of transfusion therapy, including the massive whole blood transfusion as part of treatment of certain patients. However, the transfusion of whole blood units resulted to another problem, which is known as that of your circulatory overload. Circulatory overload is a transfusion reaction that occurs when the lungs gets overwhelmed by the amount of transfused blood. And this usually happens when we give to our patient more than what they need. Like say for example, for anemic patients, they only need the RBC component. So they could be at risk of circulatory overload if we transfuse whole blood units to them even though they only need the RBC component. So this is when component therapy has been established. What is component therapy? Component therapy is part of transfusion therapy, but specifically, it only involves the transfusion of specific components, such as that of your red blood cells, platelets, and plasma, rather than whole blood to treat a patient. Primarily, this is done to avoid circulatory overload. So in component therapy, we must first identify what does the patient need. And we will be preparing that specific blood component that could answer to the condition of our patient. Now, of course, aside from its benefit wherein circulatory overload could be avoided, another advantage of using component therapy is that for a single whole blood unit, we could prepare other blood components such as packed red blood cells, platelet concentrates, plasma derivatives, and even granulocyte concentrates. So let us take note that before component therapy was established, a single donor with his or her single unit of whole blood could only save 1 patient. But because of component therapy, this single unit of whole blood can be processed for the preparation of other blood units, including packed red blood cells, platelet and granulocyte concentrates, and plasma derivatives. And this gives us the benefit of helping not just 1, but up to 3 patients. Component preparation will begin, of course, from the collection of a single whole blood unit. But we must be aware that another technique for the collection of specific blood components are actually available, and that is through the process of apheresis. But we will be talking about apheresis on another video. Now, going back is what you could see in our illustration, whole blood undergo a series of process in order for us to collect specific blood components. Primarily, whole blood will be subjected to centrifugation. And centrifugation will allow the separation of each blood components from one another. Now, there are two techniques that we could perform. We have here your heavy spin and we have that of your light spin. Heavy spin is centrifugation of blood units with an RCF of 5,000 times G for approximately 5 minutes, whereas a light spin includes the centrifugation of blood units at an RCF of 3,200 times G for approximately 2 to 3 minutes. So depending on the blood components that we want to achieve, we will be using either heavy spin or that of your light spin. Once whole blood is collected, it can now be subjected to centrifugation either with a heavy spin or a light spin. Whole blood units spun with heavy spin will result to the formation of your packed red blood cells and also that of your platelet poor plasma. These platelet poor plasma could be subjected to rapid freezing for the formation of your fresh frozen plasma. On the other hand, when whole blood units are initially spun with light spin, aside from the packed RBC formed, a platelet-rich plasma will also be formed. So as what you can see here, the type of plasma that accompanies the packed red blood cell unit will depend whether you initially used heavy spin or light spin. In heavy spin, again, the plasma that accompanies the packed red blood cell is poor of platelets. But initially, with your light spin, the plasma that accompanies the packed red blood cell is rich with platelets. Now, this platelet-rich plasma could further be subjected with heavy spin and result to the formation of your platelet concentrate and your platelet poor plasma. Again, this platelet poor plasma could be subjected to rapid freezing for the formation of your fresh frozen plasma. Fresh frozen plasma upon request could be used for the preparation of your cryoprecipitate and your cryosupernatant. So in order to achieve such components, FFPs will be thawed and will be subjected again to heavy spin, forming that of your cryoprecipitate and that of your cryosupernatant. Now, this illustration we have just discussed only gives us an overview of how each components are prepared. First in our list for specific component preparation is whole blood. Whole blood units are primarily indicated for increasing red cell mass and blood volume, particularly for our patients who are severely bleeding. Whole blood units contains red blood cells and plasma, which allows it to rapidly replenish the amount of blood lost by our patient. However, we must take note that other cells such as that of your platelets, WBCs, and even clotting factors do not survive in whole blood units. One of the contraindications for the transfusion of whole blood are for patients with severe chronic anemia, because in this case, they have very low red blood cell which is compensated by increasing the plasma volume in order to maintain a total blood volume. So basically, for patients with severe chronic anemia, they would only require the transfusion of the red blood cell component and not the plasma component. So if we transfuse whole blood units to this type of patient, they will be at high risk for circulatory overload. Now, once whole blood units are transfused, a single unit is expected to increase the patient's hemoglobin and hematocrit by 1 grams per TL and 3% respectively. For its preparation, of course, there's no need for centrifugation since this is a whole blood unit. So commonly, we are collecting an approximate amount of 450 to 500 ml per blood bag. The hematocrit of each blood unit must be maintained at 38%. For its storage, remember that whole blood units after collection are stored at rough temperature, approximately at 1 to 6 degrees Celsius. When it comes to its shelf life, it actually is dependent on the anticoagulant that is used. If you could remember, there are several non-toxic anticoagulants used, such as the following. So we have your acid citrate dextrose, your ACD, your CPD, your CP2D, which will give our whole blood unit a shelf life of 21 days, and we have your CPDA1, wherein with this anticoagulant, whole blood units will have a shelf life of up to 35 days. Next, we have our packed red blood cells, or our PRBCs. Now, packed RBCs are primarily indicated for increasing the patient's red cell mass and the delivery of oxygen towards the tissue, which is what is meant by increasing the patient's oxygen capacity. So, as what we have already mentioned, your packed red blood cells are primarily recommended to be transfused for patients with severe anemia. A unit of packed red blood cell should be able to increase the patient's hemoglobin by 1 to 1.5 grams per DL and the patient's hematocrit by 3 to 5%. As what you could notice, the ability of your packed red blood cell to increase the patient's hemoglobin and hematocrit is higher compared to that of your whole blood. That is primarily because for packed RBCs, we have a concentrated amount of red blood cells, which causes its higher ability to increase the patient's hemoglobin and hematocrit respectively. For its preparation, if you could remember our illustration, your packed red blood cells could be prepared from the heavy spin or light spin of our whole blood units. But of course, after centrifugation, we must be able to remove 200 to 250 ml of plasma. Since for packed red blood cells, we must have a concentrated amount of red blood cells. So we have to remove most of the plasma component that was originally present in the whole blood unit. And one important thing that we need to maintain when we are preparing packed red blood cell is the hematocrit of our packed red blood cell unit. Take note that for each unit, the hematocrit should be less than 80%. This is to facilitate an easy infusion of the blood unit for our patient. Because the higher the hematocrit, the more viscous the blood unit is. And if blood is highly viscous, it would be difficult for it to be infused to our patient during transfusion therapy. As for its storage, packed red blood cells will also be stored at refrigerator temperature, approximately at 1 to 6 degrees Celsius. And just like our whole blood units, the shelf life of your packed red blood cell units will depend on the anticoagulant used. Again, we have here the list of the most commonly used anticoagulants for packed red blood cells. Your ACD, CPD, CP2D, and your CPDA1. And if you could notice, we have actually here an additional substance, which is your AS, or our additive solutions. If additive solutions are to be added for packed red blood cell, it increases the shelf life of this unit for up to 42 days. Additional specifications for packed red blood cell unit preparation may be required depending on who the recipient is. These specifications should also be met to avoid the occurrence of adverse transfusion reactions. Because of this, packed RBCs can be further prepared as the following. It could be prepared as RBC aliquots, leuko-reduced red blood cell units, washed red blood cells, and that of your frozen red blood cells. First, let's have our RBC aliquots. For this specification, these are indicated for newborns and infants who are 4 months old or younger than that, particularly in cases of fetal-maternal hemorrhage, fetal-placental hemorrhage, obstetric complication, or even in cases of iatrogenic anemia. So, if you could remember, iatrogenic anemia occurs when there is frequent blood collection from newborns that causes them to have low red blood cell count. So, since we have a patient who have a lower body mass and therefore a lower total blood volume, the amount of red blood cells to be transfused should also be lower in its volume. Once RBC aliquots are prepared and transfused, the dosage given to newborns is at a rate of 10 ml per kilogram of the newborn or the infant. And with this dosage, RBC aliquots will be capable of increasing the hemoglobin and hematocrit of newborns and infants by approximately 3 grams per dl and 9 to 10% respectively. For its preparation, of course, these aliquots will be prepared from a primary bag containing your packed red blood cell unit. So for that, we could make use of multi-packs or quad packs if we want to maintain the blood unit to be at a closed system. So in this case, there would be 4 attached containers to the original RBC bag, which will be connected through stereo connecting devices. Again, this is to maintain a closed system in transferring the packed red blood cell unit from the primary bag to the multi-packs or the quad packs. A closed system is maintained and the shelf life will be the same as that of the primary bag. So it will depend on the anticoagulant that is used. Another way for preparing RBC aliquots will be through the use of syringes. However, when we make use of syringes for the preparation of RBC aliquots, the shelf life is lowered for up to 24 hours only. So from preparation, these aliquots prepared through syringes should be transfused to the newborn or infant within 24 hours. The volume that each of these aliquot must contain should be approximately 10 to 25 ml with a hematocrit that is still less than 80%. Again, to facilitate an easy infusion during transfusion. For the storage, as what I have mentioned, the shelf life will be the same with the primary component if a closed system has been maintained, but in cases wherein the aliquot was prepared through collection by syringe, the shelf life will be shortened to 24 hours only. Next, we have our leuko-reduced red blood cells. So from the term itself, this packed red blood cell will have a lower number of WBCs present. Leuko-reduced red blood cells are indicated for the prevention of certain acute adverse reactions that include your FNHTR or your febrile non-hemolytic transfusion reactions, your TRALI or that is the transfusion related to acute lung injury, and the transmission of certain infections caused by the Epstein-Barr virus, the cytomegalovirus, and the human T lymphocyte virus. Now, in the case of the adverse reactions FNHTR and TRALI, they are actually caused by the presence of biological response mediators which are released by WBCs that have been lysed during the storage period. These biological response mediators will include cytokines such as that of your interleukin-1, interleukin-6, and your tumor necrosis factor, and also fragments of your complement proteins, which are all capable of stimulating a febrile reaction. The preparation of leuko-reduced red blood cells can be achieved by either the following techniques. First, we could perform a pre-storage leukoreduction. From the term itself, leukoreduction is done before storage of the packed red blood cell unit. That's why it's termed as pre-storage. This leukoreduction is attained through the process of filtration, wherein multiple layers of polyester or cellulose acetate nonwoven fibers will be used to trap WBCs and platelets and only allow that of your red blood cells to still pass through the filter. So, pre-storage leukoreduction primarily targets the prevention of the release of biological response mediators which are released from WBCs when they are lysed during the storage period. And as what I have mentioned, these are the biological response mediators which are responsible for the occurrence of certain febrile reactions. Another technique is what we call as your post-storage leukoreduction. So here, reduction of the WBC count is performed after the storage period. So this is usually done prior to blood issuance or before the transfusion itself, which is done at the patient's bedside. For post-storage leukoreduction, this could be achieved also through filtration, wherein specifically we are making use of third-generation filters. Again, it will trap the WBCs and platelets and will only allow the retention of red blood cells. However, the disadvantage of post-storage leukoreduction is we could not avoid the release of biological response mediators since the WBCs contained by the packed red blood cell unit were not removed prior to storage. So, there's the possibility that during the storage period, the WBCs contained by the packed red blood cell unit has already been lysed and has already released biological response mediators, which again results to adverse transfusion reaction. Now, for quality control of leuko-reduced packed red blood cell unit, the WBC count should be less than 5 times 10 raised to the 6th while maintaining 80% of the original red blood cell mass. So this is possible since we have mentioned that the filters only traps your leukocytes and platelets and allows again the retention of most red blood cells. For storage, your leuko-reduced red blood cell is still stored at refrigerator temperature approximately at 1 to 6 degrees Celsius with shelf life that can be anticoagulant dependent or within 24 hours only, particularly if it has been exposed to an open system. Next, we'll have our washed red blood cell units. Now, these units are primarily indicated for the prevention of allergic transfusion reactions, which occurs once the recipient contains anti-IgA antibodies. Since the normal population would really have IgA present in their circulation, there's a great possibility that patients with anti-IgA antibodies will receive units that contains IgA antibodies. And this could of course lead to the occurrence of allergic transfusion reactions and in severe cases, anaphylactic transfusion reactions. The preparation of your washed red blood cell is simply performed by washing the unit with saline 3 to 4 times, either by manual or automated method. Now, it should be taken note that once we wash our red blood cell units, we are actually exposing it to an open system. This is why such units should be transfused within 24 hours upon preparation. During this 24-hour period, the blood unit can be stored at refrigerator temperature, which is at 1 to 6 degrees Celsius. Lastly, we have our frozen red blood cells. Frozen red blood cell units are primarily indicated, on the other hand, for individuals who have rare phenotypes and those who will be subjected to autologous donation. Individuals with rare blood types includes those with blood type O, Rh negative phenotypes. For such individuals, it would be difficult to find compatible blood units once they are in need of it. So it is ideal for them to have their blood collected beforehand and be preserved for future use. When red blood cells are frozen at a freezing temperature, not by the power of ELSA, they will be given a shelf life for up to 10 years. However, let us take note that on cold temperatures, RBCs could not actually survive since they will be subjected to lysis and will be therefore non-viable for transfusion. So what we have to do? We need to provide RBCs a protection against the cold. So imagine giving a jacket to our red blood cells. This jacket, which is its protection against the cold, is actually in the form of certain substances which we call as that of your cryoprotective agents. Now, the most commonly used cryoprotective agent in the blood banks would be that of your glycerol. And there are 2 concentrations of glycerol that we can utilize for freezing red blood cells. The 2 concentrations of glycerol could be classified as the high volume glycerol, which is at 40% weight over volume, and the low volume glycerol, which is at 20% weight over volume. For the high volume glycerol concentration, the process of freezing could be slow and uncontrolled. Remember that a higher volume of glycerol will also provide a higher degree of protection against the cold. So the freezing process may be slow and uncontrolled. Remember also that RBCs should be frozen within 6 days if we are to use the high volume glycerol concentration. For the low volume glycerol concentration, the freezing process is said to be rapid and controlled. Because of its lower volume, a lower degree of protection against the cold is present. So, as much as possible, freezing the red blood cells should be done in a rapid manner and a well-controlled manner. In this case, packed red blood cells should be frozen within 6 hours of collection. Between these two concentrations of glycerol used as cryoprotective agent, it is the high volume glycerol which is more commonly used in blood banks. So we will be focusing on the specific phases or steps for the preparation of frozen red blood cells using the high volume glycerol concentration. This process is actually composed of two phases. We have the freezing phase and we have the thawing deglycerolization phase. Freezing phase, of course, will involve the initial glycerolization of our red blood cells to protect them from the freezing temperature to which they will be stored. So the initial step will include placing the unit on a shaker while we are adding 100 ml of glycerol. Once the addition of glycerol is done, we will be allowing the cells of our packed red blood cell unit to settle for 5 to 30 minutes in order to permit the penetration of glycerol to our red blood cells. Once the glycerolization is done, the packed red blood cells could now be frozen at an initial temperature of negative 80 degrees Celsius. Remember that from the time of the addition of glycerol, the blood unit should be frozen within 24 hours. For its storage, again, the initial temperature will be at negative 80 degrees Celsius, and the maintaining temperature for the rest of the storage period should be maintained at negative 65 degrees Celsius. By the time that these units are needed for transfusion, of course, we could not directly transfuse a frozen unit to our patient. So we will proceed to the thawing and deglycerolization phase. Again, this occurs prior to transfusion. So the first step is to thaw the frozen RBC unit in a water bath at 37 degrees Celsius. And then the deglycerolization process will take place. So this, of course, will involve the removal of the cryoprotective agent, which is our glycerol, because we have to make sure that the cryoprotective agent is mostly removed before it is transfused to our patient. So deglycerolization involves washing with 12% NaCl, followed by 1.6% of NaCl and 0.9% NaCl with 0.2% of dextrose solution. Once thawed and deglycerolized, this RBC unit should be stored at 1 to 6 degrees Celsius, which is refrigerator temperature, for only 24 hours. That means after thawing and deglycerolization, the RBC unit should be transfused within 24 hours. This is because, again, it has already been exposed to an open system. For the differentiation of the high volume and low volume glycerol, we have here this table. So for the first one, we have the instruments which are needed for the freezing of the RBC units. So we have the mechanical freezer for your high volume and liquid nitrogen for low volume glycerol. Now when it comes to the instrument, of course, the instrument required by the high volume glycerol is much simpler compared to that of our low volume glycerol. Initial freezing temperature for high volume glycerol is at negative 80 degrees Celsius, while for our low volume glycerol, initial temperature is at negative 196 degrees Celsius. Maintaining temperature for high volume glycerol is at around negative 65 degrees Celsius, while for low volume glycerol, it is at negative 120 degrees Celsius. The freezing process is what we have already said. For high volume glycerol, it is a slow and uncontrolled process, but for the low volume glycerol, it should be rapid and a controlled freezing process. Next, we have the preparation for our platelet concentrate units. These units, on the other hand, are indicated for patients who are thrombocytopenic or our pre-operative patients, particularly those with platelet counts that are less than 50,000 platelets per UL. For the preparation of our platelet concentrates, they could either be prepared from random donors or single donors. Random donor platelets are those which are prepared from whole blood units. These whole blood units initially centrifuge at a light spin, then recentrifuge at a heavy spin. Plasma will be separated and will be removed from the platelet concentrates, and we will be allowing our platelets to settle for approximately 1 to 2 hours before they are agitated for the rest of its storage period. It is important, however, to remember that not all plasma should be removed and separated from the platelet concentrate. A small amount of plasma shall be maintained in order to achieve a total volume of our platelet concentrate at approximately 50 to 70 ml. Maintaining this volume is important for us to also maintain the pH of our unit at 6.2 or higher than that. Random donor platelet concentrate should contain at least 5.5 times 10 to the 10th platelets. Typically, 6 to 8 units of our random donor platelets are pulled together for the preparation of a single platelet dose. Remember that once pulled, these products must be transfused to the patient within 4 hours of pulling. On the other hand, single donor platelet concentrates are prepared through the process of apheresis, wherein we will only be collecting platelets from our donor. The rest of the blood components of our donor will be transfused back. Single donor platelets are generally indicated for patients who have become unresponsive to random donor platelet concentrate therapy, particularly because they have already developed alloimmunization resulting from multiple transfusion of random donor platelet units. The volume for single donor platelet unit is approximately at 300 ml and should also be maintained at a pH of 6.2 or higher. For storage, remember of course that our platelet concentrate should be stored only at room temperature with continuous agitation for approximately 5 days, which is the shelf life for these units. To further differentiate random donor platelets from single donor platelets, we have here this illustration. For the amounts of platelet that they contain, our random donor platelets again must contain at least 5.5 times 10 to the 10th per liter of platelets, whereas single donor platelets which were collected through apheresis will have a higher yield of platelet at approximately 3 times 10 to the 11th per liter. For the total volume, RDPs will approximately have 50 to 70 ml total volume, and SDPs will have 300 ml. Since your RDPs have lower platelet content, they will only be capable of increasing the patient's platelet count by 5,000 to 10,000 per UL, whereas SDPs are capable of increasing the patient's platelet count by 30,000 to 60,000 per UL. So as what you can see, single donor platelets are much more effective in increasing the total platelet count of our patient, which is why for every single donor platelet unit, 4 to 6 RDPs is the equivalent. Now, just like our packed red blood cell units, your platelet concentrate could also have certain specifications depending again on who will receive the unit and at the same time for the purpose of avoiding adverse transfusion reactions. Platelet concentrates can be further prepared as platelet aliquots or leuko-reduced platelets. For platelet aliquots, these are also indicated for neonates with bleeding or platelet counts which are less than 50,000 per UL. For its preparation, we simply centrifuge our platelet unit and remove the plasma. We could also achieve the preparation of platelet aliquots by the use of a syringe which is attached to the primary bag in order to acquire the aliquot volume. Dosage of our platelet aliquots given to neonates is at the rate of 5 to 10 ml per kilogram weight of our newborn. For leuko-reduced platelets, they will be prepared in the same manner as that of your leuko-reduced packed red blood cell. So this is done through filtration. Particularly, RDP Leuko-reduced should have a WBC count which is less than 8.3 times 10 to the 5, and for Leuko-reduced SDP unit, the WBC count should be lower than 5.3 times 10 to the 6. Next, we have our granulocyte concentrate units, which are indicated for neutropenic patients or those patients with very low neutrophil counts, particularly for those who no longer respond to standard antibiotic or anti. For its preparation, granulocyte concentrates could also be acquired through the process of apheresis. During WBC apheresis, the donor could actually be given corticosteroids or granulocyte colony stimulating factor in order to have a higher yield of WBC collected and at the same time increase their survival rate during storage period. For its storage, granulocyte concentrates must be transfused within 24 hours after its preparation. During the storage period, they can be stored at room temperature without continuous agitation. Lastly, we have here our irradiated components. Irradiated components are primarily indicated in order to prevent the occurrence of graft versus host disease, wherein viable lymphocytes of the donor, which is present in the unit to be transfused, could attack the cells of the recipient, particularly if our patient is immunocompromised. For the preparation of irradiated components, this includes the application of radiation, particularly of gamma rays, to our blood units. So the dose of radiation is at 25 gray at the center of our blood container and 15 gray at any other point. Cesium-137 or cobalt-60 may be used for this purpose. For its storage, the temperature will be the same depending on the unit which is irradiated. Like say for example, if a whole blood unit is irradiated, then the blood unit will also be stored at 1 to 6 degrees Celsius. And that will also follow for irradiated packed red blood cells, platelet units, or granulocyte units. The shelf life will either be the original out date or 28 days from irradiation, whichever comes first. So say for example, if the original out date of the whole blood unit is for 35 days, but that particular whole blood unit has been irradiated, so its shelf life will be decreased to 28 days from the date of irradiation. Again, whichever of these two dates comes first will be the shelf life of irradiated blood components. So that ends the first part for our discussion about component preparation. So we've already talked about preparing whole blood units, packed red blood cells, granulocytes, and at the same time our irradiated components. For the plasma component preparation, including that of your fresh frozen plasma and other plasma derivatives, I will be discussing it in my next video. I hope you had a great time learning from this video. And always remember, you can, you will, because you're amazing.